Hello everyone. Welcome to today's session on hemodynamic monitoring and shock management. My name is Dr. Sulla, and I'm very happy to be here with all of you. This topic is crucial in ICU care, and together we will review the key concepts and practical skills you need. Let's get started. This slide shows the 5 basic concepts of hemodynamics. Everything we assess in ICU, fluids, blood pressure, shock, relates back to these 5 items. Preload is the amount of blood filling the ventricle at the end of diastole. Afterload is the resistance the heart must push against to eject blood. Contractility refers to the heart's intrinsic pumping strength. Cardiac output is how much blood the heart pumps out per minute. And overall, circulation is a closed-loop system. The heart generates pressure, blood flows through the vessels, and returns back to the heart. This slide explains the difference between preload and afterload in a simple way. Preload means stretch. It is the amount of blood returning to the ventricle at the end of diastole. More blood coming in more stretch of the heart muscle before contraction. Afterload means squeeze. It is the pressure the heart must push against to eject blood out of the ventricle. Higher vascular resistance, harder for the heart to squeeze the blood out. So remember, preload equals stretch. Afterload equals squeeze. Now that we understand the basic hemodynamic concepts, we can look at what hemodynamic monitoring actually means. It is essentially a real-time, quantitative assessment of how the cardiovascular system is functioning. The purpose of monitoring is very practical. It gives us objective data that helps guide our decisions at the bedside, for example, whether a patient needs more fluids or whether we should adjust a vasoactive medication. It also allows us to evaluate how well the patient responds to our treatments and ensures that oxygen delivery and tissue perfusion remain adequate. Understanding what we monitor helps us decide what each patient truly needs. We generally divide hemodynamic monitoring into non-invasive and invasive methods. Non-invasive monitoring includes NIBP, heart rate, respiratory rate, SpO2, temperature, and ECG. These give us essential baseline information, but they can be inaccurate in low perfusion states, and repeated cuff cycling may cause discomfort or even skin injury. Invasive monitoring, such as continuous arterial blood pressure, CVP, PA pressures, and PAWP, provides accurate, real-time data and is especially valuable for unstable patients. However, it requires vigilant nursing care to prevent complications like CLABSI, thrombosis, or bleeding. When we interpret hemodynamic data, a few key parameters guide most of our clinical decisions. MAP, normally 70 to 105 millimeters of mercury, reflects overall organ perfusion pressure. For unstable or shock patients, maintaining a MAP above 65 millimeters of mercury is the usual target to protect vital organs. CVP, with a normal range of 2 to 8 millimeters of mercury, tells us about right ventricular preload. What matters most is not a single number but the trend. Low CVP may indicate hypovolemia, while high CVP can suggest right ventricular failure or fluid overload. Urine output is one of the simplest and most reliable indicators of perfusion. We aim for more than 0.5 milliliters per kilogram per hour, which suggests adequate renal blood flow. Lactate, normally less than 2 millimoles per liter, reflects tissue hypoxia and anaerobic metabolism. Lactate clearance is a powerful marker of whether resuscitation is successful. When we use invasive monitoring, the accuracy of the values is important, but patient safety and infection prevention are even more critical. Strict sterile technique is essential during insertion, dressing changes, and whenever we access any port. This is our main defense against CLABSI. All connections must be secure, and unused ports should always be capped. Part of safe practice is assessing every day whether a line is still necessary. At the start of each shift, we confirm zeroing and leveling to ensure reliable readings. Alarm limits should match the patient's condition so that real instability is recognized immediately. And finally, we document everything clearly: the insertion site, dressing condition, and all hemodynamic values. When we talk about hemodynamic instability, we're essentially describing a mismatch between oxygen delivery and oxygen demand. If this imbalance continues, organ failure follows, so early recognition is essential. One of the most valuable tools we have is actually non-invasive clinical assessment. A bedside examination is the fastest way to detect poor perfusion. Patients often show signs such as tachypnea, tachycardia, confusion, weak pulses, mottled skin, or low urine output. All of these reflect inadequate global circulation. Another simple and reliable indicator is capillary refill time. It can be checked quickly and reflects peripheral perfusion. A normal CRT in adults is usually within 3 seconds. Beyond clinical assessment, we rely on several non-invasive tools to strengthen our evaluation. Blood pressure monitoring is especially useful for stable patients, but hypotension remains one of the most important signs in shock. From these readings, we calculate the MAP. Using the formula, MAP is calculated as systolic pressure plus twice the diastolic pressure. All divided by 3. MAP represents the average systemic pressure across the cardiac cycle and is one of our most reliable indicators of organ perfusion. Pulse oximetry gives us continuous information about arterial oxygen saturation, which is a key component of oxygen delivery. A drop in SpO2 may signal early respiratory compromise or worsening perfusion. For staff trained in its use, POCUS point-of-care ultrasound adds powerful information. It allows rapid assessment of cardiac contractility, IVC collapsibility to estimate volume status, and helps rule out life-threatening causes of obstructive shock, such as pericardial tamponade. When non-invasive tools are not enough, especially in unstable patients, we rely on invasive monitoring, and the arterial line is one of the most important examples. An arterial line, usually placed in the radial artery, provides continuous and accurate blood pressure readings. Before inserting it, we must confirm adequate collateral circulation, often with an Allen test. It also allows us to obtain blood gases and labs frequently without repeatedly sticking the patient. From a nursing standpoint, we focus heavily on safety. We assess the insertion site and the distal extremity for signs of ischemia, hematoma, or infection. We make sure the system is flushed and patent, and we maintain the pressure bag at 300 millimeters of mercury to prevent backflow and keep the line functioning properly. This diagram shows the basic setup of an arterial line system. The catheter is inserted into the artery and connected to the tubing system, which leads to the transducer. The transducer converts the arterial pressure into an electrical signal displayed on the monitor as a waveform. Above it, we have the pressurized flush bag, kept at 300 millimeters of mercury. This continuous slow flush prevents blood from backing up into the tubing and keeps the line patent. On the monitor, we can see the characteristic arterial waveform, which gives us real-time and highly accurate blood pressure readings. After assessing arterial pressure, we also look at pressures on the venous side. Central venous pressure, or CVP, represents the pressure in the vena cava and right atrium. Its normal range is 2 to 6 millimeters of mercury. CVP helps us estimate venous return and right ventricular preload. It is measured through a catheter placed in the vena cava. Moving further along the circulation, we have pulmonary artery pressure, PAP. PAP reflects the pressure inside the pulmonary artery. Typical values are systolic 15 to 25 millimeters of mercury, diastolic 8 to 15 millimeters of mercury, mean 10 to 22 millimeters of mercury. PAP can be measured during right heart catheterization or by using a pulmonary artery catheter such as a Swan-Ganz catheter. These measurements give us valuable insight into right heart function and pulmonary circulation. These images help us visualize where CVP and PAP are measured in the body. On the right, we see the setup for central venous pressure. The catheter sits in the vena cava or right atrium, and the transducer system displays the venous waveform. CVP reflects venous return and right ventricular preload. On the left, the diagram shows pulmonary artery pressure measured with a pulmonary artery catheter. The catheter passes through the right atrium and right ventricle, and its tip rests in the pulmonary artery. PAP provides information about right heart function and pulmonary circulation, and it is essential when evaluating patients with complex shock or heart failure. PCWP is an indirect measurement of left atrial pressure and left ventricular end diastolic pressure. In other words, it helps us estimate left ventricular preload, which is something CVP cannot tell us. PCWP is obtained through a pulmonary artery catheter. A small balloon at the catheter tip is inflated briefly, occluding a small branch of the pulmonary artery. When the balloon is inflated, the catheter sees the pressure coming from the left side of the heart. The normal PCWP range is 6 to 12 millimeters of mercury. Because wedging affects blood flow, there are important nursing responsibilities. We inflate the balloon slowly, using the exact volume specified, usually no more than 1.5 milliliters. Inflation time must stay under 15 seconds to avoid pulmonary infarction. We allow the balloon to deflate passively, never aspirate air. And we must confirm that the waveform returns from a wedge waveform back to a PA waveform. If it stays wedged, we notify the provider immediately. This diagram shows the pathway of the pulmonary artery catheter and the different ports it contains. The catheter enters through a central vein, travels into the right atrium, passes through the right ventricle, and eventually reaches the pulmonary artery. Its multiple lumens allow us to measure different pressures and perform various assessments. The proximal port sits in the right atrium and is often used for CVP measurements or medication infusion. The distal port lies in the pulmonary artery and measures PAP. The balloon port is used for brief inflation during the wedge maneuver, and the thermistor measures temperature for cardiac output calculations. With the balloon inflated, the catheter tip occludes a small pulmonary artery branch, allowing us to obtain an indirect measurement of left atrial pressure, what we call the PCWP. This table brings together the hemodynamic patterns seen in the major types of shock. Recognizing these patterns helps us choose the right treatment quickly. Hypovolemic shock typically shows a low CVP, low cardiac output, and high SVR, because the body is trying to compensate for blood or fluid loss. Cardiogenic shock is the opposite problem. The pump fails, so CVP and PA pressures rise, cardiac output falls, and SVR increases as the body tries to maintain perfusion. In distributive shock, especially sepsis, vascular tone drops. CVP may be normal or low. MAP often requires vasopressors to maintain above 65 millimeters of mercury, and cardiac output may be high early on but becomes low in later stages. Obstructive shock, such as pulmonary embolism, cardiac tamponade, or tension pneumothorax, shows high CVP, low cardiac output, and increased SVR, because something is physically blocking venous return or forward flow. Recognizing these hemodynamic signatures helps us identify the type of shock even before all labs or imaging are available. After reviewing the hemodynamic patterns, it's important to return to the fundamental definition of shock. Shock is a circulatory failure in which the cells cannot use oxygen effectively. It is not simply low blood pressure. It is a severe and life-threatening state where oxygen delivery does not meet cellular metabolic demands. When this mismatch occurs, cells become hypoxic and shift into anaerobic metabolism. Lactate rises, acidosis develops, and if the imbalance persists, organs begin to fail. Without prompt correction, shock ultimately leads to multi-organ dysfunction and death. Now that we understand what shock is, we can look at how it progresses through stages. In the early or compensated stage, the body is still able to maintain perfusion. The signs are subtle, mild tachycardia, restlessness, and anxiety. Blood pressure may still look normal because compensatory mechanisms like our AAS and catecholamine release are working hard to keep it up. In the progressive or decompensated stage, these mechanisms begin to fail. Blood pressure drops, tachycardia worsens, breathing rate increases, urine output falls, and mental status becomes altered. At this point, organ perfusion is clearly compromised. The irreversible or refractory stage occurs when cellular and organ damage is so severe that even aggressive interventions cannot reverse the process. Death becomes inevitable if the shock is not corrected before reaching this stage. This chart summarizes the 3 stages of shock in a very visual way. In the compensated stage, blood pressure may still be normal, but the body is already redirecting blood to vital organs such as the brain, heart, and adrenal glands. We see tachycardia, delayed peripheral perfusion, and decreasing urine output. In the decompensated stage, perfusion can no longer be maintained. Anaerobic metabolism increases, acidosis worsens, renal function declines, and the patient becomes less responsive to inotropes. Hypotension appears and the deterioration can be rapid. The irreversible stage represents severe multi-organ dysfunction. Despite treatment, metabolic acidosis becomes refractory, the response to medications is poor, and ultimately this stage leads to death. Shock can be grouped into 4 main types. Hypovolemic, not enough volume, like hemorrhage or dehydration. Cardiogenic, the pump is failing, such as MI or severe heart failure. Distributive, vessels are too wide, most commonly sepsis or anaphylaxis. Obstructive, blood flow is blocked, for example PE, tamponade, or tension pneumothorax. Each type of shock has a characteristic hemodynamic pattern. In hypovolemic shock, the mean arterial pressure decreases, the CVP or preload decreases, the cardiac output decreases, and the systemic vascular resistance increases. In cardiogenic shock, the mean arterial pressure drops significantly, the CVP or preload increases, the cardiac output drops severely, and the systemic vascular resistance increases. In distributive shock, especially early septic shock, the mean arterial pressure decreases, the CVP may be low or normal, the cardiac output is high in the early phase but becomes low later, and the systemic vascular resistance is markedly reduced. In obstructive shock, the mean arterial pressure decreases, the CVP or preload increases, the cardiac output decreases, and the systemic vascular resistance increases. Recognizing these patterns helps us identify the type of shock at the bedside. This illustration summarizes the 4 main types of shock. Distributive shock happens when the blood vessels become excessively dilated, causing poor distribution of blood flow. Hypovolemic shock occurs when the body does not have enough circulating volume. Cardiogenic shock results from the heart failing to pump effectively, leading to a marked drop in output. Obstructive shock occurs when something physically blocks the heart from filling or ejecting blood, which also leads to reduced output. All 4 forms are life-threatening conditions that require immediate recognition and treatment. Shock affects multiple organ systems. Cardiovascular signs include fast heart rate, low blood pressure with a mean arterial pressure below 65 millimeters of mercury, and weak peripheral pulses. Neurological signs include anxiety, restlessness, and confusion, which may progress to lethargy or even coma. Renal signs include low urine output, typically less than 0.5 milliliters per kilogram per hour. The skin may become cool, pale, clammy, or mottled, and capillary refill may take longer than 3 seconds. Respiratory signs include rapid breathing as an early compensatory response to remove carbon dioxide. Together, these findings indicate worsening tissue perfusion and cellular distress. In caring for a patient in shock, the first priority is to maintain the airway and support breathing. Ensure the airway is open and give supplemental oxygen to improve oxygen saturation, while also anticipating whether mechanical ventilation may be needed. Next, focus on circulation by establishing large intravenous access, preferably 2 sites, starting fluid resuscitation as ordered, and preparing for the use of vasoactive medications. Continuous monitoring is essential. Place the patient on a cardiac monitor with pulse oximetry, obtain vital signs frequently, prepare for the possibility of arterial and central line placement, and insert a Foley catheter to measure hourly urine output accurately. These actions help stabilize the patient and guide ongoing treatment. In managing a patient in shock, the first step is to ensure safety and call for help from the rapid response team or the provider. Position the patient appropriately, such as supine or in a modified Trendelenburg position if blood pressure is low and no contraindication exists. Provide high-flow oxygen using a non-rebreather mask. If intravenous access is not already available, establish it quickly. Place the patient on continuous monitoring and obtain a full set of vital signs. Most importantly, stay with the patient and offer reassurance while continuing ongoing assessment. Fluid resuscitation is the first-line therapy for hypovolemic and distributive shock. Crystalloids, such as Ringer lactate or normal saline, are the fluids of choice. The nursing role includes giving fluid boluses, for example 30 milliliters per kilogram in sepsis, using a large-bore intravenous line. The response must be monitored closely, looking for improvement in the mean arterial pressure, a reduction in heart rate, and better urine output. At the same time, It is important to assess for fluid overload by listening for crackles in the lungs, watching for a rising central venous pressure, and checking for peripheral edema. Norepinephrine is the first-line vasopressor for septic shock, providing strong alpha-1 vasoconstriction with some beta-1 support for contractility. Epinephrine is used for anaphylactic shock and can also be a second-line option for septic shock or refractory cardiogenic shock. Dopamine should be used only in highly selected patients, such as those with bradycardia and hypotension, because it carries a higher risk of abnormal heart rhythms. Dobutamine is mainly an inotrope for cardiogenic shock, increasing contractility and improving cardiac output through beta-1 stimulation. Vasopressors and inotropes are used when shock continues and the mean arterial pressure remains below 65 millimeters of mercury despite adequate fluid resuscitation. When giving vasopressors or inotropes, nurses must pay close attention to safety. These medications should be administered through a central line to reduce the risk of extravasation and tissue injury. The dose should be adjusted according to the patient's mean arterial pressure response and in alignment with unit protocols. Nurses must also watch for side effects, including fast heart rate, abnormal heart rhythms, signs of myocardial ischemia, and signs of peripheral ischemia. The entire point of treating shock is to restore oxygen delivery. Therefore, maintaining oxygen saturation above 94% is a priority. In severe shock, the work of breathing can consume a tremendous amount of the body's oxygen supply. For this reason, mechanical ventilation is often necessary not just to support oxygenation, but to reduce this metabolic demand, freeing up oxygen for other vital organs. The nurse's role here involves managing the ventilator, ensuring patient comfort and sedation, and preventing complications like ventilator-associated pneumonia. This flowchart outlines the initial approach to a patient with possible shock. First, determine whether the clinical condition is consistent with shock. If so, secure the airway, establish intravenous access, obtain blood for laboratory tests, and give a bolus of intravenous fluids. Then decide whether any life-saving or early intervention is needed, such as chest tube placement for tension pneumothorax, pericardial drainage for tamponade, epinephrine for anaphylaxis, antibiotics for severe sepsis, or emergency treatment for hemorrhage or major arrhythmias. If the patient stabilizes, proceed with a focused history and examination. If the patient does not stabilize, continue resuscitation and begin empiric therapies based on the most likely causes. This flowchart outlines the ongoing evaluation of a patient with undifferentiated hypotension or shock. After the initial stabilization, the clinician looks for evidence pointing toward distributive, cardiogenic, hypovolemic, obstructive, or mixed shock based on history, physical examination, and bedside findings such as jugular venous distension, lung crackles, or signs of fluid loss. Laboratory studies, imaging, and point-of-care ultrasound help refine the diagnosis. If a likely diagnosis is identified, the pattern of cardiac chamber size and contractility further distinguishes the shock type. For example, small hyperdynamic chambers suggest distributive shock, large poorly contracting chambers suggest cardiogenic shock, small chambers with reduced filling suggest hypovolemic shock, and right-sided dilation or pericardial effusion suggests obstructive shock. If the diagnosis remains unclear, echocardiography and additional testing are used to guide further management. Now let's talk about hypovolemic shock. This type of shock happens when the body loses too much intravascular volume, either from bleeding or from severe dehydration. Because of this volume loss, the preload becomes low, so CVP decreases. Cardiac output also drops because there simply isn't enough volume returning to the heart. To compensate, the body increases systemic vascular resistance, so SVR goes up. Clinically, the patient often appears cold and dry. For nursing care, the first priority is volume replacement. We give crystalloids, colloids, or blood products as ordered. At the same time, we must find and control the source of fluid loss, such as applying pressure to external bleeding. We also monitor hemoglobin, hematocrit, and coagulation labs. Finally, we keep the patient warm because hypothermia can worsen coagulopathy. Cardiogenic shock occurs when the heart pump fails, leading to low cardiac output and poor tissue oxygenation. The key hemodynamic signs are High CVP or PAWP, very low cardiac output, high systemic vascular resistance patients are usually described as cold and wet because of poor perfusion and pulmonary congestion. For nursing care, the main priority is to improve contractility and reduce afterload. We give inotropes, such as dobutamine, and vasopressors like norepinephrine if the patient is hypotensive. Fluids must be used very cautiously, and sometimes diuretics are needed to remove excess fluid. Finally, prepare the patient for potential interventions such as IABP or PCI if the cause is acute myocardial infarction. Septic shock is a severe form of sepsis caused by overwhelming infection leading to circulatory, cellular, and metabolic dysfunction. Key features include low CVP, high cardiac output, and very low SV are in the early hyperdynamic phase. Patients often appear warm and flushed. Nursing care focuses on measure lactate level early, obtain blood cultures before giving antibiotics, administer broad-spectrum antibiotics as soon as possible, give fluids rapidly, usually 30 milliliters per kg of crystalloid for hypotension or lactate greater than or equal to 4. If hypotension persists after fluid resuscitation, start vasopressors, with norepinephrine as the first-line agent to maintain MAP at or above 65 millimeters of mercury. Now let's review anaphylactic shock and neurogenic shock. First, anaphylactic shock. This condition is caused by massive vasodilation and capillary leak due to histamine release. For management, the first-line treatment is intramuscular epinephrine. Because airway swelling can occur, always secure the airway early. Provide aggressive fluids, corticosteroids, and antihistamines as supportive therapy. Next, neurogenic shock. This type of shock occurs when there is a loss of sympathetic tone, often from spinal cord injury above the level of T6. It leads to vasodilation and bradycardia. Management includes maintaining spinal immobilization, giving fluids carefully, and using vasopressors if the patient is hypotensive. If the patient has significant bradycardia, atropine or cardiac pacing may be required. Obstructive shock occurs when a physical blockage prevents normal circulation. Common causes include cardiac tamponade, tension pneumothorax, and massive pulmonary embolism. The hallmarks of obstructive shock are high CVP, low cardiac output, and high SVR. Always look for specific clinical signs based on the underlying condition. Monitoring in shock focuses on continuous evaluation of perfusion and early signs of improvement. Hemodynamically, we expect the mean arterial pressure to stabilize above 65 millimeters of mercury and for the heart rate to return toward the normal range. Renal function should improve, with urine output rising above 0.5 milliliters per kilogram per hour. On the metabolic level, the lactate level should steadily decrease, indicating lactate clearance and improved cellular oxygen utilization. Neurologically, the patient should become more alert and oriented as perfusion improves. Peripheral perfusion should also show clear signs of recovery, including warmer skin, improved color, and a faster capillary refill. All of these parameters together help us determine whether resuscitation is effective and whether the patient is moving toward stabilization. Here are the main references used for this presentation. They include major critical care guidelines, standard nursing textbooks, and high-quality journal articles. Please feel free to review them if you would like more detailed information. Thank you for your attention. I appreciate your participation, and I hope today's session helps you feel more confident in caring for critically ill patients. If you have any questions, please feel free to ask.